Okay, so let's start our today's discussion. Okay, let me share my screen. Can you guys just see my screen?
No, no.
Okay,
Okay, now yes.
Yes.
okay, yes. Okay, so today we are going to discuss some retinal disorders, right? So we already discussed that we have a structure that is known as retina, and retina is important for your vision, especially the area which we discussed fovea, right? And just like for example, if this is our retinal layer, so we have a structure which is known as fovea, and here we have the maximum visual acuity, right? And surrounding this area, fovea is basically known as macula. We already discussed it, right? So we'll be discussing some retinal disorders, some commonly seen and really high yield, right? So the first one which we are going to discuss is age-related macular degeneration, right? Okay, let me just okay. Age-related macular degeneration. Okay, as the name suggests, age-related macular degeneration. It means that the macular part which we discuss is, an area which is surrounding your fovea. With age, it can undergo degeneration, and that's simply known as age-related degeneration of your retina, right? And what we are going to see like central vision loss or scotomas, right? So you guys are already aware of the visual pathway. Whenever, for example, if this area is knocked off, you already know we have rod and cones there, which helps in our vision, our colored vision, and our vision at night rods, for example, right? So whenever they are degenerated, we are going to see like a scotoma, like that area is going to be deficit. You cannot see with that, right? So you'll be like seeing a black kind of structure. For example, if here we have degeneration of these rods and cones, right? So that's basically known as scotoma. So there are two variants of age-related macular degeneration. It's very important to know. The first one is dry, and we have wet. So what is dry? Actually, what happens in dry that like whenever an individual is having age related macular degeneration and the dry variant, he will be having vision loss, but that vision loss is going to be gradual, right? So we are going to have gradual vision loss. Remember, right? So you have a U-word MCQ on that as well. For example, if you see an individual with increased age and gradually his vision is decreasing, think of this condition, right? Okay, and what else we are going to see on the retina, that is the subretinal layer, like below the retina, we are going to see a deposits which are known as drusens, right? So we are going to see drusens. And what are drusens? Drusens are simply like white area which you can see like on your fundoscopy, which indicates the ischemia, or which basically indicates that this area have undergone degeneration of the retina, right? So D for dry and D for drusens. Is that right? Okay, so sometimes what happens, this dry variant of age-related macular degeneration can go into wet variant of age-related macular degeneration. And what happens in this variant of the disease, that we are going to have rapid vision loss. And why do we call it as wet, or why do we have rapid vision loss? That whenever we have drusens formation there, it would lead to ischemia or hypoxia, right? And remember, whenever in the eye, like it's a general term, you guys must know that whenever we have hypoxia within the eye or within the retina, what happens, there is going to be release of a substance which is known as VEGF, right? What is VEGF? Yes, vascular endothelial growth factor, right? So what VEGF is going to do, it's going to start proliferation of new vessels. So it's going to lead to neovascularization. Are you guys getting me?
Yes.
Yes, sir.
Okay. So what happens that the dry can be, like as we discussed, it can transition into wet variant of age-related macular degeneration. And furtherly, we are going to have like neovascularization. And if we have neovascularization, a lot of vessels, so that tough of vessel, it can undergo bleed, right? So if we have bleeding there, obviously it's going to lead to rapid vision decrease, right? Or rapid decrease in vision, right? And what's the characteristic feature of this pathology? We are going to see a condition which is known as metamorphopsia. So what is metamorphopsia? Anyone know that?
No, sir.
Okay. So metamorphopsia is simply a term used, for example, if this individual just sees some straight lines, we cannot see it as straight. The straight lines would appear like, wavy kind of distortion of straight lines, right? He cannot see that straight lines. It would be like in a kind of wavy form, which is known as metamorphopsia, right? So we discuss age-related macular degeneration, 2 variants. Okay, so you have a UL MCQ. For example, if I have an individual who is like transitioned into wet variant of age-related macular degeneration, so we are going to give him anti-VEGF. Is that clear? It's going to be the treatment. Why? Because we do not want those new blood vessels to grow there and cause further problems. Similar is the case with diabetic retinopathy. In diabetic retinopathy, again, we are going to have chronic hypoxia, and again, you have like again 2 variants which we'll be discussing. But the hallmark of diabetic retinopathy is also like increased neovascularization, and anti-VEGF is basically given. So it's basically given in a form of injections. Like for example, if you have your eye, for example, if this is your cornea, so here we have a part of eye which is known as pars plana. Remember, right? Pars plana, and the pars plana basically have less layers, right? So basically we are going to give this injection through the pars plana. Remember that, right? Is that clear? Hello?
Yes.
Yes,
Okay, so
Yes.
pars plana is the part of an eye where basically we are going to give this VEGF injections, right? So whenever you have an a condition which lead to neovascularization, anti-VEGF is one of the treatment options. Is that clear? This was all about age-related macular
Oh, it's
degeneration.
B.
that's fine.
Okay, so let's discuss our next condition, that is diabetic
Retinopathy.
retinopathy, right? So,
Sorry if I'm slow right now. So,
Okay.
mhm.
any questions? Hello?
No, sir.
No,
Okay.
sir.
So let's discuss our next condition, that is diabetic retinopathy, right? So as the name indicates that, for example, if you have an individual with diabetes, what is the hallmark of diabetes? Increased glucose, right? It can also lead to retinopathy. How? Because the hyperglycemia itself would increase the permeability, right? And once the permeability of the blood vessels are increased, what happens? It will lead to occlusion of your retinal vessels. And once the retinal vessels are occluded, it's going to cause problems, right? If the blood vessels are compromised, it's obvious that retina would undergo some problems. So again, we have 2 variants of diabetic retinopathy. That is non-proliferative, and we have proliferative. So what happens in non-proliferative or diabetic retinopathy variant, as we know that if we have like occlusion of the retinal vessels, right, due to hyperglycemia, occlusion of retinal vessels. If they are occluded, they would just become thinned. They would become like narrow, right, the blood vessels. And it would in turn lead to microaneurysms, right? Microaneurysms, and those microaneurysms in turn, they can rupture, right? If those microaneurysm ruptures, it can cause problem, right? And there are some characteristic features which you are going to form or see on fundoscopy, that is cotton wool spots. So cotton wool spots are again a whitish kind of spot, which basically we are going to see, like for example, you are going to if let's suppose on fundoscopy, this is your retina, okay, this is your optic disc, you have some blood vessels coming out of that. So you are going to see like a whitish materials. It would resemble a cotton wool, simple, right? Just as cotton is white, right? So cotton wool, these are the hallmarks of non-proliferative diabetic retinopathy. The other variant is proliferative. So as the name indicates, we are going to see proliferation. So proliferation of what? The idea is really clear. If the retinal vessels are occluded, if they undergo microaneurysm, the idea is really simple. Again, we are going to have hypoxia, right? Chronic hypoxia of your retina. And whenever we have hypoxia of retina, it would just release VEGF, right?
Yes.
And VEGF in turn would lead to neovascularization, right?
Yes.
We're going to have neovascularization. So if we have neovascularization, what happens? It can be also known as proliferative, or simply you can think of, we are going to see proliferation of blood vessels. Why? Due to hypoxia, due to VEGF. Is that right? So what would be one of the treatment options for the proliferative phase of diabetic retinopathy? Yes.
Anti-VEGF.
Anti-VEGF. Perfect. And what else can it do? Like, for example, if you have abnormal blood vessels, for example, in the vitreous, it can also undergo hemorrhages, right? And those hemorrhages, like for example, okay, I'm just giving you a theory kind, right? You can just imagine. For example, if you have hemorrhages, right? So right after hemorrhages, we have a formation of granulation tissue. We already know that. For example, in the healing phase, right? So the granulation tissue itself has some contractile, filaments, right? So it can cause contraction, and further this contraction, for example, if we have hemorrhage, if we have, let's suppose, you can think of, right, if we have a granulation tissue, so it can just pull the retina, right? So whenever we pull the retina from its vascular layer, that's known as retinal detachment, if you guys know that, right? So it can also lead to retinal detachment if you have hemorrhage, if you have formation of new blood vessels, if you have a form of granulation tissue, it can lead to the tractional force, which can cause retinal detachment. Is that clear?
Yes.
Okay, perfect. So this was all about diabetic retinopathy. Let's discuss our next condition, that is hypertensive. You have a UWorld MCQ on each and every pathology which we are discussing here, right? Hypertensive retinopathy, right? So we are already aware that hypertension can cause a lot of problems, right? For example, if an individual is having chronic hypertension, so can you guys tell me what's the impact of hypertension on blood vessels? What do you think will happen?
Weakens it.
Constriction and
Okay,
illness.
we already know that. For example, if this is our blood vessels, if we have hypertension, if you guys discuss, we can have fibrinoid necrosis. Remember, the only variant of necrosis which is associated with hypertension, fibrin would just deposit, it would lead to necrosis, right? What else? We already know whenever we have hypertension, so the blood vessels would adapt in a way that it would become thickened, right, in order to withstand this increased pressure. Is that right? So what would happen? In hypertensive retinopathy, we are going to have fibrinoid necrosis of the retinal vessels, right? And again, we are going to see sclerosis. If the fibrin is depositing there, it would lead to sclerosis of the retinal vessels. That's obvious, right? And again, we can have spasms as well, right? So all of these three phenomena, that is sclerosis, we can have fibrinoid necrosis, and we can have spasms, right? If you have disruption, or like we are going to have spasm, right, due to endothelin release. So all of these phenomena would lead to weakening of the blood vessel wall. If we have weakening of blood vessel wall, we already know that weakening of blood vessel wall is followed by aneurysms, right? So we can again see microaneurysms. Is that clear? Hello? Okay, and what else would happen if we have thickening of these blood vessels? Like, for example, again on fundoscopy, if this is your optic disc, you're going to have blood vessels coming out of that optic or disc. So what happens that we are going to have thickening of these blood vessels, right? They would undergo thickening. As we discussed, it's one of the compensatory mechanism to increase hypertension, that the blood vessels are going to undergo thickening, right? So what happens? These thick blood vessels can compress the surrounding veins, the retinal vein. You can simply think of, if we have vein, we already know that in the veins, the blood. Okay, Dr. Shafiq, can you just please fix your mic? There's some noise. Thank you so much. We already know that arterial systems are high pressure systems, while the venous systems are low pressure systems. If we have thickening of the blood vessels, the arteries, what would happen? That would just compress the surrounding veins, as they are low blood pressure systems. And this compression of the surrounding veins are basically known as arteriovenous nicking, right? Arteriovenous nicking. Is that clear? So due to this thickening of blood vessels, we are going to have compromise or compression of your venous, which is known as arteriovenous nicking. Is that clear?
Yes.
Okay, perfect. So as we discussed, we can also see formation of microaneurysm, and the idea is really clear. Microaneurysm can rupture. Once they rupture, what happens? The retina is going to undergo ischemia at that point, right? And ischemia in the retina again is going to appear as cotton wool spots, right? So these spots basically indicate that we have ischemia of retina going on there. Is that clear?
Yes, sir.
Okay, perfect. So we can also have papilledema if the veins are compromised, right? If we cannot, like for example, if these are our veins, right, and we are just compressing the veins, right? So ultimately the blood is going to enter into the veins. If we are compressing the veins, it means blood again is going to build in the arteries, right? if you cannot drain it out. So what happens? Increased hydrostatic pressure due to venous compression. We are going to have increased hydrostatic pressure, and increased hydrostatic pressure, you guys know, it would lead to edema, right? It would just pull all of the fluid outside. Is that clear? And edema in this case is known as papillary edema, right? Hello?
Yes, doc. Yes.
If you guys already know that, for example, if we have our like second cranial nerve, we already, the optic nerve is surrounded by CSF, if you guys remember, right? And in hydrocephalus, we also know that one of the hallmark of hydrocephalus is papillary edema, right? Why? Because this increased CSF can again compress the veins. And as the veins are compressed, if you cannot draw out the deoxygenated blood, so what happens? It would build in the arteries. Again, it can lead to papillary edema. And how would papillary edema appear on the fundoscope? Like normally we see an optic disc, right? So it would be like bulging out, right? You can simply see you have a U-word MCQ and you have bulging out of that central optic disc. It basically indicates papillary edema, right? And you cannot even see the fovea because the fovea is, like a cleft kind of structure, right? Why? Because all of the layers of the retina are very less at the fovea. That's why we have more visual activity, right? So if we have edema, what happens? This bulge is going to be like that. It's going to bulge out due to papillary edema. Is that clear? Hello?
Yes, sir.
Hello? Okay, perfect. So let's discuss our next condition, that is retinal artery occlusion. Retinal artery occlusion. So we can have occlusion of retinal artery. We already know the pathway, right? From the internal carotid, we have ophthalmic branches. If you guys remember the blood supply, from the ophthalmic, we have retinal, right? So for example, if you have an emboli that's going, you have a UL MCQ on that, right? So it can travel, it can occlude your retinal artery. And once the retinal artery is occluded, you are just compromising the blood supply to the retina. So how would it appear on the fundoscope? It would appear pale. It would just appear pale. Why? Because you're compromising the main blood supply of retina. So it would appear pale. Is that clear? So simply whenever on the fundoscopy, you see whitish kind of your retina, simply think of that there might be retinal artery occlusion. You have a UL MCQ on that. Is that clear? But remember the foveal component which we discussed, the fovea is going to appear red. And why is that so? Because the fovea isn't, fed by retinal vessels. It have its own blood supply. So what happens in retinal artery occlusion? The idea is really simple. It can be due to embolus. Whenever the embolus block of the blood supply, all of the retina is going to appear pale, while the fovea is going to appear bright red. That is cherry spot, right? Why? Because it have its own blood supply. It's going to appear red. No problem. Is that clear? So cherry red spot at fovea and paleness of your entire retina is going to lead you to the diagnosis of retinal artery occlusion. Is that clear? Hello?
Yes, Doctor.
Yeah.
Yes.
Okay.
Yes.
So how to identify the emboli? The idea is really clear. For example, if we have cholesterol emboli, we are going to see crystals, right? We are going to see like hollow spaces, right? So that's simple, I guess. Okay. Is that clear? Hello?
Yes, sir.
Okay,
Yes.
perfect. So let's discuss our next condition, that is retinal vein occlusion, right? So we have retinal vein occlusion. What happens in the retinal vein occlusion? Basically, we can have like central due to thrombosis, right? For example, if the thrombus develop within the vein and it just blocks off the vein, it can lead to retinal vein occlusion. We already discussed if the vein is occluded, it can lead to a lot of problem. If we aren't draining out, the deoxygenated blood through veins, it would just build within the arteries, right? Hello?
Yes.
And again, if the blood is built within the artery, it would lead to arteriovenous crossing. That is, we are going to have sclerotic artery, which will again compress the venules, right? Why? If you have a lot of blood, again, if I'm not draining out the deoxygenated blood, so it would just stay within the artery. And whenever the blood stay within the artery, again, it's going to lead to thickening, right? And thickening again can lead to compression of your veins. Is that clear? Hello?
No,
Okay.
no, I couldn't get it. Would you please explain more? Thank
Okay,
you.
no problem. Okay, for example, these are your arteries, right? The arteries in the end is going to, join with the capillaries, and from the capillaries, it's going to drain all of the blood through veins. Is that clear? This is the normal pathway. Is that
Yes.
clear? So, for example, if I have a thrombus that is formed within the retinal vein, right? And I've occluded this part. Now, what happens? The blood cannot flow, right? So, it would start building back within the arteries. Can I say that?
Yes, sir.
If it starts building back within the arteries, so your arteries, again, due to compensatory mechanism, they would dilate, they would become thickened, and this thickened artery in turn can compromise your veins. Again, they can, because veins are low pressure circuits, right? So it can compromise. And this phenomena is basically known as, okay, we are going to have sclerotic arteriole, and it would compress the venules, causing turbulent blood flow, right? So the blood flow is going to be turbulent. So we are going to see venous engorgements, right? So in the veins, again, the blood vessel is going to pool. So the veins are going to, be appearing as engorged vein, right? It's also known as like blood and thunder appearance, right? So this appearance of venous engorgement is known as, yes, what's the name for that? Blood and thunder appearance,
Thunder.
right? Guys, blood and thunder. The idea is really simple. We have occlusion. All of the blood is going to, build back. The veins are going to be like, engorged. And besides that, it's also going to back up within the arteries. Arteries are going to become thickened. And again, further, it would just compress the veins, right? So the problems would be worsened. Is that clear?
Yes, thank you.
Okay, perfect. So let's discuss our next condition, that is retinal detachment, right? Retinal detachment. As the name indicates, whenever the retina gets detached from the pigmented epithelium, that's simply known as retinal detachment. Or retina is basically the neural component, right? We have a lot of rod and cones, we have ganglion cells, if you guys know, right? Okay, so whenever we have separation of this neurosensory retina, right, it's a neurosensory because it senses the lights, simple, right, from the underlying pigmented layer. What happened that we are going to have loss of the blood supply. If you guys remember, for example, if this is our eye, we discussed it's our sclera, then we have our choroid, and then we have our retina, right? If I'm detaching the retina, what would happen? Yes, if the retina detaches, normally the choroid feeds your retina, right? The choroidal vessels. It feeds the retina. If we have separation of the retina due to certain processes or due to certain pathology, which we'll be discussing in a while, it would lead to loss of choroidal blood supply, right? And if the choroidal blood supply is lost, it would lead to hypoxia of the photoreceptors. Now we do not have blood supply because we have detached the retina, we have pulled off the retina from the choroidal, so it would undergo ischemia or hypoxia, right? Is that clear?
Yes.
Hello?
Yeah.
Okay. So
Can
basically,
you, can you repeat this point?
okay, no problem. We discussed we have our sclera, we have our choroid. Choroid is simply a tuft of blood vessels which feeds your retina, right? You have a retina layer, which is a neurosensory layer. It would just pick all of the sensory light. It have a lot of rods and cones, simple, right? So due to certain process, for example, if I just hold this retina and I just detach it, normally the retina is going to be in close association with choroid for its blood supply, right? If I detaches the retina, the idea is really clear. Now you do not have blood supply to the retina. Retina would become hypoxic and it would start degenerating. The photoreceptor are going to start degeneration. Is that clear now? Hello?
Yes, it's clear.
Yes, sir, it's clear, right?
Okay, perfect. So what happens? There are two variants of retinal detachment, right? The first variant is known as rhegmatogenous, which is the most common variant, and the other one is known as non-rhegmatogenous, right? So what happens in the rhegmatogenous variant, it's the most common. It's basically due to tear of the retina. Like for example, if the retina tears due to some pathology, right? If it tears, what would happen? Yes. Hello? Like for example, if we already know that we have a vitreous humor here, right? So sometimes what happens that due to, let's suppose, certain inflammations, like this vitreous layer can be attached like it's in close association with your retina. So for example, if you have problems with the vitreous tumor, right, so the vitreous is going to pull off this retina with itself, and it would just cause tear of the retina, right? And it's basically due to advanced age and due to high myopia. What happens in myopia? Yes. What happens to the size of the eyeball? Is it big or small?
Big.
Small.
Big or small? I have two answers.
Small.
Oh, myopia.
It's big
It's
or
small.
small.
It's small. It's small. Sorry, it's in front of the fovea, so it's small.
If it's in the front of the fovea, so it's small or big? I think it's big.
It's a long.
Oh, this
Big
is
like
big.
eyeball.
What
I'm
size
not
big?
confused. I mean,
Eyeball
it's big. Sorry,
in my-
it's big if
It's
it's in front of
small.
fovea, correct?
Yes, if it's in front of the
Big,
fovea,
big.
it's
It's
big.
big.
And the
Ah,
eye, yes.
thank
So what
okay.
happens in myopic individual, if we have a big eye, what happens? So we have a vitreous. This vitreous can, pull off the retina with itself. It can tear the retina, which can lead to this variant that is rhegmatogenesis. Is that clear? And trauma as well. For example, if you have trauma to the eye and we just displace the vitreous in that, right? So it can again tear or pull off the retinal layer, which is known as rhegmatogenesis variant of retinal detachment. Is that clear? It's due to retina tear. Is that clear?
Yeah.
Okay. So as we discussed, it's the most common variant. It's due to retinal tear. How do we get tear? For example, in an individual with myopia who have big eye, and let's suppose we have a traumatic injury. So what happens? It can just pull off the retina, right? Or increase advancing age can also do that, right? Posterior vitreous detachment, right? So this part of the retina is basically going to detach. Then we have non-rhegmatogenesis. What do we mean by non-rhegmatogenesis? That's basically due to like exudates, right? For example, if we have exudates here, right? Like let's suppose if you have infection, and infection leads to exudative, of effusion kind of substance. So what would happen as a result of that? We are going to see like attraction force. Let's suppose if we have a lot of exudate, and for example, if this exudate in the end stages of recovery lead to fibrosis, right? Simply you can think. So this fibrosis with exudate they can again pull off the retina. So there would be attractional force due to this fibrosis. It would start pulling the retina with itself, right? And that's basically known as non-rhegmatogenesis, right? So the only difference between rhegmatogenesis and non-rhegmatogenesis is rhegmatogenesis is due to, advanced age, due to myopia, while the non-rhegmatogenesis is due to attraction or due to exudate or fluid accumulation, right? So if you have a lot of fluid accumulation as well, it can also disrupt the retinal layer. Is that clear? So what would be some common symptoms of an individual having retinal detachment? So he would be having floaters and light flashes. So what are the floaters? Like simply he would just see some floating things, right, within his visual field. Why? And again, he would be seeing dark curtains. So he would be saying that suddenly my eyes, like all of my vision go dark, right? If we have some dark curtains coming in front of my eyes, simple, right? Because due to that traction forces and due to that detachment of retina. And it's a surgical emergency. You have to, treat it like, immediately. And what else are we going to see on fundoscopy? The idea is really clear. If we are pulling off the retina, it's obvious that we are going to have a wrinkling of the retina. The retina would be wrinkled, right? Because we have pulled it off, it isn't present in its normal location, so it would be wrinkled. Is that clear? So we have wrinkled retina. Is that clear?
Yeah.
Oh, okay, perfect. So let's discuss our next pathology, that is retinitis pigmentosa. So you already did an MCQ today on that question. So you guys are going to tell me a lot, right? Retinitis.
Doc, why there will be floaters? Can you just explain?
Okay, so the idea is that, for example, if we have retinal detachment, right? Let's suppose if it's due to exudates. So we are going to have like some exudates which are just coming in between your, your normal, like, the light is going to fall like that on your lens, and through the vitreous, it's going to fall on your fovea, right? So for example, if you have some exudates or some remaining component of the detached retina, so it would impede the normal pathway of light. And once it impedes the normal pathway of light, there at that point, you are going to see floaters, right? Is that clear?
Yes.
Okay. Okay, so let's discuss our condition that is known as retinitis pigmentosa. So what is retinitis pigmentosa? You guys are going to be telling me that. Yes. Yes. Please do participate.
It's a group of eye disease that affects
Okay.
the retina.
Inherited disease in which what we are going to see, we are going to have progressive degeneration of the photoreceptor, especially which photoreceptor, the rods or cones?
The cones.
Cones.
Cones?
The rods.
Okay, so we are going to have a specifically degeneration of rods, right? So the rods are going to be degenerated. That's why we are going to have night blindedness, because rods are important for your night vision, if you guys remembered. Yes or no? Am I right?
Yes. Yes.
So we are going to have night blindness. Why? Because, and rods are also present, as we know that, for example, if it's our fovea, so fovea have a lot of cones, right? And on the periphery, you have a lot of rods, right? So if you have degeneration of the rods, you are going to have two problems. Can you please fix your mic? Okay, thank you. If we are having degeneration of rods which are present on the periphery, we are going to have two problems. First of all, night vision problems. And what else? We are going to have problems within the periphery. That is, the peripheral vision is going to be lost because we have a lot of rods present in the periphery. Is that clear?
Yes, tunnel vision.
Sorry?
It means tunnel vision.
No, it isn't basically a tunnel vision. We are going to discuss that, but you can simply imagine that the peripheral vision is going to be blurred and it's going to be, problematic, right? So the term which is used for night blindness is also known as, yes, what's the term used for night blindness?
Nyctalopia.
Tunnel vision.
Nyctalopia.
Nyctalopia,
Tunnel
yes.
vision.
Okay, nyctalopia, right? So it was all about retinitis pigmentosa. So let's discuss our next condition, which is very interesting condition. That is retinopathy of prematurity, right? Retinopathy of prematurity. So we'll be discussing it in a little bit conceptual way, right? So as we know that whenever a fetus is present, okay, we have a fetus, right? So fetus is already hypoxic. We already know that, right? Am I right?
Yes,
Hello?
yes.
If you have a baby within the uterus, if you have a fetus is already hypoxic. We already know that, right? If whenever a fetus is hypoxic, so we are going to have hypoxia everywhere, even in the eye. Can I say that? Hello? Hello?
Yes,
You
yes,
guys
doctor.
agree?
We can hear you. Yes, we
Okay.
can hear you. Yes.
Okay. So please do participate as well. If you have hypoxia within the eye, we are going to have release of VEGF. We already know that, which would
Yes.
lead to formation of your retinal vessels,
Vascularization.
right? Neovascularization. But in baby, we need that. We need retinal vessel to grow. So for example, if you have a baby and he is premature, he have premature birth, right? So whenever he's premature, what happens now? You are just like, for example, at 26th week, this baby is born, right? If he's born now, the hypoxia, he'll be having hyperoxia, right? That is a lot of oxygen. So if you have a lot of oxygen, now what happens? VEGF is going to be less. And at this time, we do not need VEGF to be less. Are you guys getting me?
Yes, sir.
Yes,
We need
yes,
a
sir.
lot of VEGF at 26 week, but the problem with this baby that he was born premature, so now the VEGF would decrease. For example, if we already know that this baby is going to be premature, so premature baby have a lot of problems. This baby can develop one of a condition, NRDS, if you guys remember, neonatal respiratory distress syndrome, right? So if initially this baby is born, we are giving him oxygen, we are basically stopping his retinal vessel growth. Are you guys getting me?
Yes.
Yes.
Yes, sir.
And once we remove the oxygen, for example, this individual won't be having surfactants as well. And if we have less surfactants, again it would lead to NRDS, again it would lead to hypoxia, right?
Yes, sir.
Right. Sir.
Okay, so hypoxia again what would it do? It would increase VEGF. But this time, this VEGF is going to be like really high. It's going to cause extreme vascularization, extreme neovascularization, right? And this extreme neovascularization is going to cause tractional retinal detachment, right? as we discussed, if you have a lot of blood vessel growing on there, it would pull off the retina with it itself. And whenever it's pull off the retina, it would cause retinal detachment. And this condition is known as retinopathy of prematurity. Is that clear?
Sorry,
Yes,
Doctor.
sir.
Let me just
Yes, sir.
Yes. Repeat just one more time.
let
Try
me
to explain
okay.
it more.
Let me repeat it again. We have fetus. Fetus is hypoxic. In hypoxic condition, what happens to VEGF? It's increased. And it
Yes.
should be increased in fetus because we want normal development of retinal vessels.
Yes.
Is that clear? Okay.
Yes.
Now,
Yeah,
for
but-
example, if this baby is born premature, right? He's born. Now his oxygen level are increased. For example, at 26 week, as we discussed. So normally at 26 week of a baby, it shouldn't be decreased. But what was a mishap? He just born premature. And if you are increasing the oxygen, VEGF would stop.
Yes.
Right? VEGF stop. Retinal growth stops, right?
Yes.
Okay, but with prematurity, there are a lot of problems as well. That is like, for example, if you have a
Lungs.
26-week-old baby, what would we do? We would obviously put him on oxygen therapy, right?
Yes, we will.
Yes, so actually putting him on oxygen therapy causes problems. It would decrease the
Decrease the
VEGF.
VEGF more.
And once we just withdraw this oxygen therapy, he'll be having NRDS, let's suppose if this individual have. So what happens? Again, it would increase VEGF because NRDS causes hypoxia. And this VEGF would now increase to certain extent that it would cause excessive neovascularization. This excessive neovascularization is going to pull off the retinals. We are causing retinal detachment, which is known as retinopathy of prematurity. Is that clear?
Yes. But I have a
Okay.
question. If we
Yes,
have
please.
anti-VEGF drugs, don't we have VEGF where if a premature baby is born, we can give, as we are giving oxygen, although we can give supplemental, like
Okay,
say,
so basically the baby's eyes, the pars plana is very weak to give anti-VEGF, right? So like it's a problem which, like for example, if you have like excessive retinal detachment, right? So the VEGF won't help like that, right? The VEGF won't help because it's due to excessive activity of VEGF. Even you cannot, like there are a lot of problems you can think of. Like first of all, you cannot directly give baby a VEGF, right? Anti-VEGF. Is that clear?
okay. Mm-hmm.
Due to like
I have a
weakened eye
question.
structures, you cannot administer through the pars plana, right? So it was all about the pathologies. So let's move a
I have
little
a
bit.
question.
Yes, please.
Does it only happen to premature babies? Or
Yes,
it
it
can happen
happens.
to any baby that receive oxygen at
No, it happens to
premature age?
premature baby, right? In mature baby, we already have like maximal development of the retina, right? So here the problem is whenever he is born premature, we are stopping the retinal growth. Normally, like we need 36 weeks, for example, for the normal retinal vessels to grow. So if we have a mature baby that of 36 weeks, let's suppose, so he won't be having problems because his retina is developed to his maximum extent, and this condition won't cause any problem. Is that clear?
Okay, thanks.
Okay. So let's discuss. Okay, so we are left with only small topics. We have all discussed most of them. So now we are going to have a question and answer session, right? Like for example, Horner syndrome. You guys already know that. You guys already know that internuclear ophthalmoplegia. So I'll be asking you some questions, and you guys are going to tell me, right? Hello.
Okay, yes.
Okay, so Dr. Daniela is going to tell us what is meiosis. Please, you should be like a little bit slow.
Yes. I'm
Yes.
sorry. Meiosis is just constriction of your pupil.
Okay, so can you just tell me that we have like two systems, sympathetic nervous system and parasympathetic. Can you just tell me the impact of both of them on pupillary constriction and dilation, please?
Constriction is for parasympathetic and dilation is for your sympathetic.
For sympathetic. And simply you can think of, for example, if you have an individual with sympathetic response, fight and flight. So we need a lot of dilation, right?
Yes,
You need-
yes.
need a
Because you
lot
need
of-
more light
Dr.
into the
Shafiq,
eye.
can you please fix your mic? Okay, thank you so much. Okay, so meiosis basically is constriction, which is basically due to parasympathetic. So can you just tell me which nerves do supply or do give parasympathetic innervation to your constrictor muscle?
Your oculomotor cranial of 3.
Cranial nerve 3. And what is the nucleus responsible for that? What's the name of that nucleus?
Edinger Westphal nucleus.
Oh,
Yes, Edinger-Westphal nucleus, right? So what's the normal pupillary light reflex pathway? For example, cranial nerve 2 is going to take like the light, and it's going to go into pretactal nucleus, which is present in your brainstem, right? From the
Yeah.
pretactal nucleus, we are going to have innervation to Edinger-Westphal, and Edinger-Westphal is going to give parasympathetic to your to your ciliary ganglion, and from the ciliary ganglion, you have short ciliary nerve, which would just cause. Okay, let me just draw it, right?
Yes, please.
Okay, so let's discuss our pupillary light reflex. So we discussed that. Okay, just give me a second. So we discussed that basically parasympathetic causes meiosis, while sympathetic causes, what's the opposite of meiosis? What's the term used for?
Mydriasis.
Mydriasis.
Dilation.
Perfect, right? Meiosis and mydriasis, right? So what happens? We have normally pupillary light reflex. Like for example, if these are our eyes, so what happens? Your cranial nerve 2 is going to take all of the, like the light. It's going to go into your midbrain here, where we have a nucleus which is known as pretactal nucleus, right? So this pretactal nucleus is going to innervate further two nucleuses, which are your Edinger-Westphal nucleus, which are associated with your cranial nerve 3, right? So from here, the fibers would enter into ciliary ganglion, right? And from the ciliary ganglion, we have short ciliary nerves, which would just innervate your, which muscles?
Sphincter pupillae muscles.
Sphincter pupillae muscle, and it would cause constriction. Is that clear?
Yes.
Okay, so we have light coming to pretactal. From the pretactal, Edinger-Westphal, which is the parasympathetic nucleus associated with cranial nerve 3. From here, we are going to have fibers to the ciliary ganglion. And from the ciliary ganglion, we have short ciliary nerves, which would innervate your constrictor pupillae. Is that clear?
Yes.
For the mydriasis, we already know that, okay, so the pathway for it is like a little bit complicated, right? So you don't have to fall within that. Simply, if you know that the sympathetic nervous system basically causes mydriasis or dilation of your pupil, right? And we already know that we have a first order neuron which is going to come from the hypothalamus. You already know that, right? So the second would just go into a, you have like paravertebral ganglions for the sympathetic. Second order neuron is going to go like that. Third order neuron is going to go along with, if you guys remember, your carotids, right? And it would just further go and innervates your eye, let's suppose, the dilator. What else? It's going to innervate the superior tarsal muscle, right? Am I right? Hello?
Yes.
And what
Yeah.
about sympathetic innervation to your sweat glands,
Sweat gland. Okay.
right? So for example, lungs basically come here. For example, okay, so this is the first order neuron, your second order neuron, and third order neuron. So for example, if you have Pancoast tumor, it can compromise the third order neuron. So we are going to have three deficits, right? First of all, we are going to say meiosis. If the sympathetic nervous supply is gone, if you cannot dilate, the parasympathetic is going to dominate. It's going to cause meiosis. Am I right?
Yes.
What else? The superior tarsal muscle, basically it would just open the eye. So if the innervation to superior tarsal muscle is gone, it would lead to ptosis
Ptosis.
and anhydrosis,
Anhydrosis, lack of sweat.
which is known as Horner's syndrome. What else? For example, if we have a surgery and we cut off the carotid, let's suppose, we have increased chances of knocking off the third order neuron as well. Am I right? So we have long ciliary nerve. This is basically your long ciliary nerve, the third order neuron. Is that clear? Hello?
Yes, sir. Mm-hmm.
Can you repeat
Okay.
the compression of the first two ones before the superior tarsal?
Okay, so we discussed that from the hypothalamus we have first order neuron. The first order neuron would synapse in the lateral horn. You remember?
Yes, sir.
From the lateral horn we have second order neuron, where we have a parasympathetic. We have a sympathetic, chain which lies like paravertebral, right? It would just go to the cell bodies there. From there we have long ciliary nerve. It would innervate which muscles for dilation? Yes. For the eye dilation, it would innervate which muscles? Dilator pupil, right?
Yes, sir.
Right? So it's going to innervate the dilated pupillary. Okay, and what else? It's going to innervate the superior tarsal. Like for example, if it's our upper eyelid. So we have a muscle that is superior tarsal, the muscle, right? So it would innervate that, and what else? It would also innervate the sweat glands, right? Am I right? So what happens if you have, let's suppose due to pain cause tumor, if you compromise or if we block off this long ciliary nerve, what happens? We are going to have three deficits. First of all, meiosis. Why? If we cannot dilate, so it means that eye would be constricted. The parasympathetic from Edinger Westphal is going to dominate, right?
Yes, sir.
And it would cause constriction. What else? The innervation to superior tarsal muscle is gone, so it would lead to ptosis. We are going to have, the upper eyelid would be low, right? So that's basically known as ptosis. You all are aware of what is ptosis, right? And we are going to have anhidrosis. That is the innervation to the sweat glands are gone. So this individual won't, sweat at half of his face, right? Ipsilateral loss of sweating, which is known as anhidrosis, right? No water, anhidrosis, no sweat. Is that clear?
Yes, sir.
Yes.
Oh, okay. So it was all about Horner syndrome. Let's discuss our, okay. So we already discussed the innervation. We discussed the cranial nerve. We already discussed in quite detail. So let's just have a question and answer session on that. So Dr. Abdurrauf is going to tell us the innervation of third cranial nerve. Yes, you should be quick.
Innervation of the third cranial nerve.
Third cranial nerve innervates which muscles?
Sir, the third cranial nerve innervates the inferior oblique muscle, medial rectus,
Okay.
and
Superior rectus.
yes, superior rectus, inferior
Okay.
rectus, medial rectus, and the inferior oblique.
Okay. And for the sixth cranial nerve?
For the sixth cranial nerve, we have the lateral rectus.
For the fourth trochlear?
Yes, the superior oblique muscle is oblique by the trochlear nerve.
Okay, perfect. So whenever we have problems with this cranial nerve, for example, with the sixth, we cannot abduct the eye, so eye would be inward, right? Similarly, if you have problems with the trochlear, as you guys know that it's important, or like superior oblique is important for which kind of gaze? Yes. Climbing up the stairs or down the stairs?
Down the stairs.
Down the stairs, right? You guys just had a UWorld MCQ. You guys already know it, right? So let's discuss our next. Okay, internuclear ophthalmoplegia. We also discussed this topic in a big detail, right? So what we have medial longitudinal fasciculars. If you guys remember, we know that they basically connect two nerves, right? Your third and sixth cranial nerve. In order to have proper horizontal gaze. Am I right?
Yes, sir.
Okay. So can you guys just tell me that medial longitudinal fasciculus is myelinated by Schwann cells or oligodendrocytes? Yes.
Oligodendrocytes.
Oligodendrocytes. Perfect. So Guillain-Barré is going to be a demyelinating disorder or multiple sclerosis?
Multiple sclerosis.
Perfect. So
Sclerosis.
if we have multiple sclerosis so it can demyelinate your medial longitudinal fasciculus, and there would be problems with the horizontal gaze. For example, if I'm looking towards the right, so sixth cranial nerve would just help. It would simply, AB duct, let's suppose my right eye, right? So, but for the opposite, we have internuclear ophthalmoplegia. So you cannot, stimulate the other nucleus, right? So there will be problem. You are going to have nystagmus there. Okay, let me just draw it again for you guys. Like as we discussed that, for example, we have our third cranial nerve and we have our sixth cranial nerve. So we have intermedial longitudinal fasciculus lined by oligodendrocytes. If we have demyelination there, so connection between these nucleus are lost, right? So for example, if an individual is looking towards right, so what happens? Here, let's suppose your sixth cranial nerve and it was your third cranial nerve. So sixth cranial nerve can simply abduct the right eye, right? But for the opposite eye, you cannot adduct, right? Why? Because the connection is lost, right? So the sixth cranial nerve is going to overfire because sixth cranial nerve want to stimulate third in order for this individual to adduct his eye. So what would happen due to this overfiring? There would be nystagmus seen in this eye. Is that clear? That is, an oscillatory movement of a opposite eye. Is it clear?
Yes.
Okay, so let's discuss our visual pathway. You guys already know that. You discuss a lot of MCQs on that, but let me just be a little bit quick, right, with that. So for example, if these are my eye, right? Let's suppose if it's my left eye and it's my right eye, right? So we know that all of the for example, this is our visual field, right? So visual field from the nasal side, it's going to form image on the opposite retina, right? That is on the temporal retina. From the temporal vision, it's going to fall off on the nasal retina. Is that clear? Again,
Yes.
here the image is going to be like that, right? So the fibers from the temporal won't decassate. It would directly enter into your lateral geniculate body of your thalamus, right? And here you guys can see again the temporal fibers won't decassate. It would enter into the lateral geniculate body. But the medial fibers or the nasal fibers, they would decassate, right? And it would just form optic chiasm, right? Then we have our optic radiations, the superior radiations and the inferior radiations, which would just enter the occipital lobe and it would just form image there, right? So I'll be just drawing a deficits in different pathways, and you are going to tell me that we are going to have problems with which eye field, right? For example, if we have an individual, right? So if he have problem with this fiber, so what do you guys think on the visual field? Which kind of deficit are we going to see?
Contralateral.
Contralateral means nasal.
Contralateral.
Unilateral, right.
Contralateral or ipsilateral?
Ipsilateral nasal
Ipsilateral,
fibers.
unilateral.
Ipsilateral will
Ipsilateral.
be affected.
Can I just draw it like that?
Yes.
Okay, perfect. For example, if we have, you guys already know that problems at the optic chiasm.
Bitemporal.
So
Bitemporal
can I say that
hemianopsia.
bitemporal hemianopsia, that
Hemianopsia.
is on the
Both.
temporal side,
Yeah. Both temporal
hemianopsia,
sides.
only half of the vision is gone, right? Hello?
Yes,
Yes.
sir.
Yes. Yes,
If you have
doctor.
problems here,
Ipsilateral.
It's going to be
yes. So on this eye, in this
Yeah.
eye, we'll be having, okay, this is my right eye and my left eye. So on the right eye, we'll be having deficit where you can just follow the pathway at the nasal side.
on the nasal side.
And what about here? You are going to have, you can just follow the path. We are going to have problems here, right?
Temporal side.
Okay, so what is this condition basically called?
Homonymous quadrantonopia, right?
Okay, okay, so
Homonymous
right
hemianopia.
homonymous,
Yeah.
right?
Hemianopia.
Okay, right homonymous hemianopia. Okay, perfect. If you are going to have problems with the superior, that is the Meyer loops, then we are going to see quadrantinopia, right?
Yes, superior is yes.
Yes, quadrantinopia. Like that, okay? And if we have problems with the lower fibers, we are going to have, okay, this is pie in the sky, right?
Pie in the sky,
s-
I'm pie on the floor.
Pie on the floor. Perfect. So we are going to have pie on the floor. If we have problems here, let's suppose. So we are going to have macular sparing. That is, macula is going to be spared. And we are going to have, right, hemianopia with
Hemianopia with macular sparing.
macular sparing, right? So this was the entire pathway. So we have a last topic remaining. We already know that cavernous sinus, right? You discussed a lot of MCQs in UWorld. So you guys are going to tell me, I won't help you in this last topic, right? And with that, we are just done with the eye module. Hope so you guys enjoyed. Okay, so cavernous sinus, which nerve go in close proximity to internal carotid? If we have internal carotid and six, perfect, Dr. Ahmad, six.
Abducent.
Six, perfect. And if we have thrombosis, we are going to, okay, which other nerves are present on the lateral aspects of your cavernous sinus? Yes.
Third, fourth, V1
Third,
and V2.
fourth,
V1 and V2.
V1 and V2, perfect. So if we have thrombosis of the entire cavernous sinus, we can have compromise of those nerves. So with this, our eye module is finished. Hope so you guys enjoyed this module, and we are going to discuss ear tomorrow. and we have some MCQs remaining. So we have covered a lot of things, and hope so you guys enjoyed. Thank you so much. Thank you for staying here, and have a nice day. Any questions?
No,
Okay, so I have
Thank
some
you so much,
announcement to.
Doctor.
Okay, so I have some announcements to make that currently for the research, as you guys already know, that a lot of students were interested. That is like more than 170 students. So for them, we have decided that we are only going to select 100 students because we cannot carry all, like a lot of students. So we recruited a big team for our research. Like we'll be having a lot of mentors, and like Dr. Abdullah Humayun, he's there in Mayo Clinic as a trainee. So he'll be also there, and we also recruited a lot of other mentors like Dr. Amna. We discussed Dr. Manahil. You already know that. We have like a lot of mentors. Dr. Farooq is also going to help you with that. And besides that, we are also making a new group, as you guys know. So we are just sending the links to those who are about to give their exam in 1 or 1.5 months. So for them, we have decided that first of all, we are going to take an NBME in a real exam environment. And right after that, NBME will be starting there. We will be separating their schedules. They're going to, run with a fast pace. We'll be integrating some high yield stuff for them, which is important for their last dedicated time period of 1 or 1.5 months, right? So you guys already know we have sent a lot of students the invite link. They're already added into that group. And before, giving your NBME, right after giving your NBME, you guys have to send us the screenshot of your exam day. Then we are going to start separate schedules for you guys, right? So this was all about the research, and we are also launching our Step 2 marathon. So we have a lot of students who have passed previously. So for them, we also have some new mentors. We'll be just introducing them to you guys. So this was all about announcements, and thank you so much, and see you tomorrow, right? So I'll be sharing my schedule within 1 hour. You guys can have a break and then come to the Discord server. We are going to discuss that. So today I'll also be joining the Discord session, right? Hello? Okay, thank you so much. Thank you. Thank you. Have a nice day. Bye-bye. No, it was basically for Step 2. The May is going to start on the 1st May, right? The dates aren't changed for the May marathon. So those who have recruited in that marathon will be announcing before the marathon. Will be just giving you the entire orientation. Don't be worried. Thank you so much.